Hello there, listeners. It's Suzi New, anaesthetist from Melbourne. Thank you for listening to our podcast. It's called Australian Anaesthesia, and it's where we talk about all things relevant to anaesthesia in Australia. One thing that occurred to me as I was editing this episode is that I, and hopefully you are too, I'm on a journey to be the best anaesthetist that I can be. And perhaps that's an underlying theme that I have for all of the Australian Anaesthesia podcast. What can we be doing that makes us better anaesthetists? Because I'm one of those people that thinks there is always something more to learn, something more I can improve upon. And wow, did I learn some things from my guest in this episode. I really like talking with people who are not anaesthetists, not even medical, because of the perspectives that they bring. This conversation made me really think about whether we, as anaesthetists who pride ourselves on alleviating pain and awareness of surgery, about how we can actually do the opposite, how we can contribute to a patient's trauma, worsen the pain they might feel, and slow down their physical and mental recovery from surgery. There's no doubt that we anaesthetists in Australia are highly trained and have a high level of knowledge and skills. One thing I've noticed recently is how much we might differ in our non-technical skills. Some people consider these soft skills, but others, and I'm inclined to agree, consider these the essential or the critical skills, the core competencies of being a good doctor. For example, I've had a number of patients who've asked me if I can tell them when I'm about to do something to them or when I'm about to start the anaesthetic, because they didn't have that experience with other anaesthetics, with previous anaesthetics. I've also had a few patients who were traumatised as children, often around cannula insertion or being restrained during an inhalational induction. And now they're returning as adults with what they think is an irrational fear of the operating suite or a needle phobia. I know this is not always avoidable, but can we do better? I really do take pride in my colleagues who shatter that myth that we went into anaesthesia because we don't like talking to people. But in fact, we are amazingly effective communicators, as we usually only have a few minutes to establish rapport and trust and reassure our patients, whilst also discussing risks and obtaining consent. That's not easy, and by and large, I think we do it well. I do think, though, that we can improve our use of non-nociceptive language, or we can better use language that helps people heal, basically. And adopting the principles of trauma-informed care, which is what we're going to explore in this episode, is important because we don't always know if someone has a trauma background. And it might be much more prevalent than we think. So who better to dive into this with than my next guest, Brigette Berry, who's a clinical psychologist based in Canberra. She works in acute care as well as with chronic pain patients, so she's very familiar with us as a specialty. She herself is neurodivergent and she brings a load of knowledge and experience in providing trauma-informed care. Let's get into it. I'm so grateful that you've given up some time this morning to join me and have a chat.
Thanks, Suzi.
Can I just go back because our listeners might not know who you are. So what's your background?
Hi, everyone. I'm Brigette Berry. I'm a clinical psychologist working here on Ngunnawal country in Canberra. I started my work in ACT education and then moved to Canberra Health Services and worked there for a while working with inpatients and outpatients across a whole range of conditions, including chronic pain. And now I work privately at ACT Pain Centre, mainly with those with chronic pain, but I also work with those who are needing support while medically transitioning, who are gender diverse.
So in your work with the Pain Centre, do you work with anaesthetists as well who are pain physicians? So you've got a good sense of who we are.
Definitely, yeah.
So today we're talking about this thing that I keep hearing about, trauma-informed care, and I wanted to do a bit more of a dive into it because I think we as anaesthetists potentially could adopt some things into our practice. So let's perhaps start by, when we're talking about trauma-informed care, what are we talking about in terms of trauma?
For trauma-informed care, I would also say that it's not just for people who have a trauma background per se. You know, I feel like it's good standard practice in that we don't have to rely on someone disclosing that they've been through something to provide good care. And for those of us who are neurodivergent, for example, these principles are still really important.
Oh, good.
So trauma. So if we're looking at the Diagnostic and Statistical Manual, DSM-5's definition, it would be experiencing a literal or perceived threat to life. So examples of that could be from a high-speed motor vehicle accident or a sexual assault, things like that. If we think about what your work is, going under in a general anaesthetic, whether it's a routine procedure or a life-saving, potentially, procedure, you could argue that perhaps it falls under that purview of perceived threat to self, given that there's small risks involved, especially depending on the severity of the procedure. I guess that would be how I would look at trauma. And of course, in the International Classification of Disorders, or the ICD-11, which is normally used in Europe, whereas in Australia we normally use the DSM-5, though we're waiting for an update on the DSM-5. So the ICD-11 is the newest diagnostical manual we have. But yeah, in the ICD-11, it also breaks up trauma into post-traumatic stress, which we typically would diagnose in single event traumas like that motor vehicle accident, something that's a time point. We also have complex post-traumatic stress disorder, which we would more use in prolonged, inescapable traumas like war, family and domestic violence, especially as children, where we can't just run away. Just to complicate things a bit further, that would also be another way to look at trauma too, is whether it's single event versus multiple continuous prolonged exposure to traumatic events.
I like what you said about we may not often get a history of trauma, especially in our work. You know, I might be giving an anaesthetic for, removal of a skin lump or something, and I wouldn't have in my routine anaesthetic assessment, I don't even think it'd be appropriate to say, oh, have you got a history of trauma? So I suppose what I'm taking away from this is whether they've got a history of trauma or neurodiversity or something, I may not uncover it, but perhaps some of the principles I have anyway are going to be useful in my interactions with them. Is that a good takeaway to have?
I'd say so, yeah. And if we think about it in terms of statistics, I think it's now like 1 in 3 women have experienced some type of interpersonal violence, as an example. So if we think about 1 in 3 patients that we see for anaesthetic procedures, that's quite high. Obviously, people of colour are experiencing discrimination way, way more than we should at all. But yeah, so I guess we can make assumptions internally in our heads around, I don't know people's stories, but there's a high proportion of those who experience traumatic events. I think going in, not probing for people's stories is not the takeaway, but like you're saying, Suzi, maybe making that assumption and then using the trauma-informed care principles to inform how we're supporting people.
I suppose before we dive into those principles, the other thing to highlight is that for those who do have a trauma history, we may risk worsening it, aggravating it, triggering it. Is that something we need to be considerate of?
100%, yeah. Re-traumatization is a very real thing. And I guess when we go through the principles, I can dive in slightly further. But we know, especially for those who have been through the more kind of chronic, prolonged, inescapable traumas that are cumulative, we're less likely to feel safe within our own bodies. And so you can imagine that with coming out of anaesthesia, perhaps, and that kind of disorientation, that could be quite alarming for people. If we already have this underbelly of dissociation from our own bodies, an idea could be preoperative, really spelling out what it could feel like when coming out of the anaesthesia, post-operative, so that when I'm waking up and it's like, oh, this is what Suzi predicted for me. I know this is okay. Yeah. So I do think it can be really helpful.
It sounds like a good time to dive into some of the principles. So broad brushstrokes, how many principles are we talking about, first of all?
Where I'm borrowing this from is Fallot and Harris 2009. So they did a Creating Cultures of Trauma-Informed Care paper. But I've also, which I highly recommend to everyone, the Blue Knot Foundation. I would say they're kind of Australian experts on complex trauma, and they do great training. So I did phase 1 of trauma-informed care approach, which is safety and stabilisation, which I would say for your profession, Suzi, is probably the go-to, because that's kind of the first phase. So it's really in that acute setting, which is why I did the training, because I was in acute healthcare.
I'll put a link to it in the show notes, but maybe before we jump into the principles, what's the training? Tell me what's involved in case anyone out there is like, yeah, I really want to do this.
I did the 2-day in-person workshop, and if you work through Canberra Health Services, you should be able to book fairly easily through the workplace. For people working in other settings, particularly privately, you might be able to ask for Blue Knot Foundation to do an in-person training for your team. It's 2 days because it's quite comprehensive. Safety and stabilisation, so it's phase 1 of a 3-phase treatment, because in your settings, phase 2 and 3 would be bonus if you're interested, but I don't think it's as needed for your day-to-day. But I could be wrong, but that's my impression.
That's good insights. It's always good to talk to people who've already done the training.
Yeah, it took so much away. And because I did it through Canberra Health Services, I was in a room with medical doctors, social workers, exercise physiologists, like pretty much a lot of professions signed up for it.
Okay, so all health professionals seem to be welcome. It's geared for health professionals and it's a 2-day face-to-face intensive, and hopefully it can be done in other settings as well. Are they based in Canberra or?
I think it's New South Wales, but they travelled out.
All right, let's get back to the principles. So how many principles are we talking about?
5.
5 principles. Okay, all right. So let's go through. What's the first principle?
So the first principle is safety. So ensuring physical and emotional safety for all that we work with, which I'll get into what's physical and emotional safety. The second one's trustworthiness, so maximising trust. And this can include clear expectations, like what I was saying before with preoperative spiel, I guess, and having kind of consistency when working with someone. Choice is the third one, so making individual choices.
Giving the patient a bit of autonomy.
Exactly. I love that word, autonomy. Yeah. The next one's collaboration, the fourth principle, which I think go hand in hand with choice, trying to bring the person as the expert in themselves together with your expertise and kind of sharing that power and working together. And then the fifth principle is empowerment, so recognizing the strengths and skills of the person and really trying to bolster a sense of hope and possibility within the setting that you're in.
Okay, they're 5. That's nice big brush strokes. Thanks. That's how my brain kind of works.
Definitely.
I like them already. So let's just dive into the first one, safety.
So with this one, making the environment and our communication and the procedures as physically and emotionally safe as possible. So with physical safety, here we're thinking about the specific geographical space that we're in. So thinking of the other principles, asking the person and collaborating with them on what makes them feel safe in the physical setting. So it could be whether it's preoperative or post-operative, seeing if there's anything we can do to change the sensory experience of the room. And obviously you're the expert, so I don't know if this is appropriate, but if there's possible lighting changes that could happen at times, or if loud noises could be reduced where possible, things like that.
I work in a centre where we look after a lot of people who have special needs. In that centre, we have more private rooms where we can put people in.
Great example.
And then we can dim the lights in that room if people are finding it a bit bright, because we're a little bit limited sometimes in what we can do in that or in the operating theatre. But just trying to think about those things or even ask about them, is that how we might address this?
Yeah, you're right. Even if we're asking the question of, is there anything else we can do in this space within reason that could make you more comfortable? That's really therapeutic than just not asking and making the person feel like they can't advocate for anything. So it could be, do you want an extra pillow under your neck? Do you need an extra blanket? Whatever it is, I think the act of asking to inquire about their physical safety in the space is a good one. And one that I'd never thought of before the Blue Knot Foundation training, which maybe I had, just not consciously, was, will the person be physically safe after? So thinking about this is what to expect for post-operative, and I know you already would do this for duty of care reasons, but who's picking you up after? Do you have a safe place to spend the rest of your day as things are winding off anaesthesia-wise? So that was a really cool point for me to make sure that I'm inquiring about how someone is after a session.
Does that encompass all the areas, even if you can't change the physical environment, but asking them, does that start to encompass or build a sense of emotional safety, or do we need to do more to look at that?
I would say it definitely starts, because I feel like we're kind of normalizing by saying, hey, some people find this to be quite an anxiety-provoking, stressful situation, regardless of your history, right? So that is also highlighting that depending on your story, this could be even harder for you. Yes, I'm aware that this can be quite stressful. Is there anything I can do to make me more comfortable? That's, again, normalizing and validating, which is already therapeutic. But then you're also leaning into those principles of choice and collaboration around, okay, what can we do right now? And it also builds into that trustworthiness principle too, where it's like, oh, Suzi gets it actually. And it could be examples like, some people find it unsettling to have the mask placed suddenly. Would you like me to tell you through each step before I do it? Or it needs to be this tightness for it to work. Is that okay? So narrating throughout what we're doing is good too.
I like that. I genuinely like to always be telling people each step. But it's so easy because we do it all the time. We do it thousands of times in our careers, and you forget that it's an everyday thing for me, but it's not an everyday thing for the person that I'm looking after. I really like your choice of words there, that you're not assuming that they're anxious. You're normalizing it in a way that you're saying some people find it, instead of saying you must be anxious.
It sits differently, doesn't it?
Yeah, it does. Yeah. So I like that choice of wording there.
And with that being said, I do think there's a place for all health professionals to have some level of training to recognize the signs of anxiety. Like if there's muscle stiffness, the breathing has quickened, things like that, it could be appropriate to say, oh, I'm just noticing these couple of things. Is this typical for you, or is this indicating something else is going on? Because, gosh, I guess it could be something medical too that you'd want to keep an eye on, but that could be another way in. As well as I'm observing things, how would you describe what's going on now? But I think if you're not seeing any verbal, non-verbal signs, it would still be helpful to use the question before and just normalize and validate, like you said, because some people can be really good at masking. And so we never really know.
And I sometimes do ask that if I see people, they've volunteered their story that they do have a history of PTSD or something. And I'll say, do you feel like you need something to make you calmer? You're looking pretty calm to me, but I don't know you. So is that a way that I can encourage them to express what they're feeling?
Yes, I love that. And I think that beautifully takes us to the emotional safety part. But before I jump in there, just another couple of things have come to mind. When I used to work in the hospital, and I would see people basically across every single ward, where we don't always think about consent in a way. So, for example, sometimes I'd be having a session with someone and it's literally at the bedside, of course, and then the doctor will come in and the patient sometimes allows me to just stay there because they know that the doctor's coming in to check the wound or whatever it is, and then they'll leave. So I got to observe how colleagues would talk to the person, or not, actually. Some of the training that I did around trauma-informed care was highlighting the unconscious stuff that we do as health professionals. Like, I'm working with a woman who's had below knee amputation, and we walk in as a health professional, maybe say hello, maybe not, and then just lift the blanket up to assess the wound. And so if we think about, and not always the case, but if I'm there as a psychologist, there's probably more happening for this person, right? And so I would talk about how part of our trauma-informed care could be every time we re-approach the patient, we have to introduce ourselves again, because the patient's swarmed with faces all the time and they don't always know who you are as either a name or as a profession, and then asking for consent. Hey, Suzi, I'm here to check your wound dressing. Is it all right if I lift the blanket here? I'll be mindful of not lifting it too high, or just actually narrating what we're doing and seeking consent. The person's aware that they're in a hospital setting, wounds need to be checked, but gaining consent makes someone feel more human, not just a MRN number. I wonder if that translates at all in your profession.
For sure. I see it all the time. We bring people into theatre and often I might be putting in a cannula or attaching the fluids. I might have a nurse who's putting on blood pressure and putting the dots on the chest for the ECG, so they're reaching down into the gown. We might have a tech, and they're usually men, putting heel pads under their heels so that they're resting their heels a bit more comfortably. I might have someone else who's applying the mask and giving oxygen, and it's all happening at the same time. And it can be really busy. But I think you're right. It only takes a few seconds to go, I'm just going to put the drip in. I'm just going to connect the fluids. Can I reach under your gown and put... I mean, the nurses are usually fantastic about that because I think we appreciate how it's sensitive. It's sticking your hand down someone's top.
Yeah.
But because we do it 10, 20 times a day, let's just try and remember that there's a person there. And I think often we do a good job, but it's always good to remind ourselves.
And even how my brain works, I would have seen hundreds of times doctors doing a beautiful job of that. But if my brain's going to highlight the stuff that I think we could have done better as health professionals, because then I'm going to problem solve around that and organise training or whatever. So, yeah, definitely not ragging on doctors,
No.
We do a really good job.
Not thinking that you are, not at all. So, yeah.
And I guess what's hard about the principles, but also good about them, is that they do overlap. So if we're thinking about the physical safety and the trustworthiness, the action of gently narrating what I'm doing, you may feel my hand on your arm now. This is the anaesthetic going in through the drip I put in, or whatever it is. Avoiding unnecessary physical contact with the person or even like sudden movements will reduce threat as well. Like we were saying before, if there's any sensory modulation that's appropriate, whether it's reduce bright lights when possible or loud noises when possible would be good. And you have a beautiful speaking voice already, Suzi, but for others, using that calm, steady tone when doing all of this will also be helpful. And then maintaining that kind of modesty and having consent where possible, just to reduce that re-traumatization.
I anaesthetise a lot of children, and I feel like all of these principles really apply for children. I don't think it's anything to do with whether they have a trauma background.
Yeah.
And you need to work a lot harder to gain their trust and to have them cooperate with you.
And that's such a beautiful example, because as humans, we find safety, physical and emotional safety, in predictability, certainty. What's pretty uncertain, especially for a kiddo who's never had surgery, is surgery. So I think the signposting and these principles for kids, yes, such a great point, that whether they've had trauma or not, really important stuff there. So I'll jump into emotional safety now. Yeah, it could be the point you were saying before around inviting someone like, hey, I'm either aware of your trauma history or I'm aware this could be stressful for some people. Is there anything that you do to help reduce any anxiety or stress that's happening? Should we do some deep breathing together? So it could be a literal question of what you already find helpful. Could also be our nonverbal communication that shows that we are supportive, focused, listening to them, even though, like you're saying, we're probably putting things everywhere on the person getting set up. But if we're especially maybe pre-operative, trying to really check in with someone, having a calm demeanour, regular enough eye contact. Doesn't have to be fixed eye contact, but just consistent enough that we're not looking distracted or that we do care. This can also be where we're checking in to see if there's any nonverbal signs that the person is anxious and encouraging them to do what could be helpful for them, whether it's deep breaths or we look around the room and name things as a mindfulness exercise. And then also checking if the person will be emotionally safe after the surgery and heading home, which can be tricky. We don't always know if someone has a safe home to go to, but I do think it's worth asking. Obviously, I've specialised in pain, so a lot of my references here to research will be in that space. But we do know that for outcomes with pain procedures like amputated limb, the more we do preoperatively in terms of pain education, clear expectations, minimising that physiological arousal from anxiety or stress does lead to better outcomes. So I'm not sure if that translates to other conditions, but this preoperative role that you have, and of course the pain team should be doing that specific pain education, but for anaesthetists, I do think you do have a powerful role in setting up post-operative outcomes.
And there's good evidence for that. I didn't realise.
At least from pain, but yeah, it's good to know that it's not airy-fairy stuff. So I'll jump to the second one, which is trustworthiness. What are some tips to build trust with the person, especially if they do have a trauma history that we're aware of? But if we've already checked in on physical and emotional safety, that is showing attentiveness to someone's safety, which can build trust, definitely. Paying ongoing attention to their verbal and non-verbal communication behaviours to see, are they now showing signs of stress or are they now looking more calm? And it could be as well very gently saying, I can see after those deep breaths we did together, you are seeming a bit more calm. Am I getting that right? Yes or no? Could be taking a gentle approach. Like obviously we have an agenda pre-operatively, post-operatively to make sure someone's okay. So it could be finding a balance of, I've got to do my tick box of my agenda to make sure everything's okay and appropriate. Is there anything else I can add in that shows someone that I see them as a human as well, not just like a person on a table as an example. listening if anything comes up.
What I get from that is actually giving that moment to focus on the patient. And I like what you said before about, yes, we do have to do a checklist. We have to check we've got the right patient and the right details and so forth. And I think you actually flag posted it. So you have that, I'm having my conversation with you and I see you as a person. But just for this moment, I just have to check these boxes off and I'm going to signpost that my communication style might be just a little bit different.
I really like that.
That's what I hear from you. It made me think about when you thought about non-verbal communication. And I saw this great video once, it was with children, and the anaesthetist was drawing up an ampule of medication while they were talking to the child. And it was just this very different signal because you focus on this big syringe and this needle and going into this glass vial. And it was a very different body language from, if they had nothing in their hands and they were actually just communicating. That's what that just reminded me of, that focusing on the patient and being aware of what your hands are doing as well.
It's a really good point. Obviously not saying we can't multitask, but you're right. If there's, maybe I'm doing the syringe with the basic kind of checklist of date of birth versus I'm checking in on your safety right now. It can sit quite differently. There's some Cochrane systematic reviews around music in preoperative care. Small effect sizes, but there's still some research around preoperative music listening, reducing anxiety compared to benzodiazepines and controls. So that could be something like, if we put on any music, would you find that helpful? Because some people might find it overstimulating, right? But for some may find that could be comforting to listen to while we're doing all our things.
Yeah. Okay. So asking the patient, giving them some choice, if we can, about what sort of music they might want to listen to.
Which actually leads up to choice, which is the next principle really easily. So this one is increasing options and choices for people. I don't know how transferable it is for your profession, but for me, I ask questions about anything I can think of. So, is it okay if I ask you about your trauma history? Do you have an idea of how that translates?
Yeah, I think we could do that either in our conversation or as we're about to do procedures. Often I think patients might not expect what happens when we give an anaesthetic in terms of the first thing I'm actually going to do is talk to people. And sometimes I'll start asking questions and they're like, why are you asking me these questions? So sometimes I'll take a step back or sometimes I'll even remember it first up and say, I'm just going to ask you a few questions, which is going to help me plan the safest anaesthetic for you. And then they go, oh, I get it. Now we're going to have a conversation. And then if there's a choice of anaesthetic, I might give them that. Then there's the things I have to do, like I have to put on the monitoring, I have to put on the drip. But I'll still often ask, I'll say, I want to put the drip in now. Is that okay?
That's what I was trying to articulately say before, is even the small choices are really powerful. If we're thinking about someone who has obviously consented to doing the procedure, right, because they're there, but there's a lot that's out of their control. And so if we can try to give the sense of more control around choice, but it's like, if you feel the cannula is uncomfortable here, can we do it somewhere else, or where would be best? Even small moments of, oh, I'm feeling a bit cold in here. Would you like an extra blanket, instead of just putting it on someone and assuming? So fostering choices for that person can be really powerful.
So don't always assume. Yeah, I like that.
So collaboration, again, quite similar. So how I would boil this down is doing something with a person rather than for or to them. So again, I guess with the blanket, would you like this, rather than just putting it on someone? The question we were saying before around some people find this anxious or stressful, instead of just launching into let's do some deep breaths together, because technically that's helpful for a lot of people. So fair assumption to make, but it's not a helpful assumption, because especially if someone has been through that more inescapable, prolonged, complex trauma, we cannot assume that anything intrapersonally, including breathing, is actually helpful or feels safe unless a lot of trauma work's been done. So for collaboration, it could be, again, signposting, hey, this is scary for some folks. Does anything come to mind for you that could be helpful for us to do together right now? Let's give this a go now. Still good intentions for both, but one is just a little bit more trauma-informed.
Do you ever, and might be a bit of a controversial question, but just say we're asking all these questions of our patients and we're saying, are you okay to jump up on the bed now? I'm going to have to undo the back of your gown. Is that all right? Can I get you a warm blanket? Would you like that? And I'm going to come and chat with you. I'm going to do an assessment first. I'm asking questions all along the way. Can it get to a point where it's like, oh my goodness, you're asking me too many questions. I just want you to take over and just be paternalistic. And if you want to give me a warm blanket, just wrap me up. Does that ever happen?
Probably. Humans are variable enough that I could definitely see some attachment types, personality styles where it's like, yeah, just do your thing, especially if there isn't perhaps sensory needs or trauma history that we're having to kind of support.
I do hear that sometimes from people. Just don't worry, love, do your thing.
That's true. Maybe it's an unspoken thing around I feel comfortable enough that I don't need you. Maybe for some people it could actually feel more confronting for someone being trauma-informed than having less choice and collaboration, because sometimes if we're not used to a high level of trauma-informed care or compassion from others, it can feel really confronting in our nervous system because we're like, oh, I didn't know I deserved this, or grief can come up.
That's so true.
It's very complex, actually, what we're talking about.
Yeah, for sure.
Yeah, so my only advice maybe, because I don't want us to throw these principles out, is maybe two ideas. One is, if you have a felt sense as the health professional that this could maybe be sensory overload, asking heaps of questions, or they might get annoyed by it, maybe at the outset saying, hey, how I would typically work is asking heaps of appropriate but more questions than you maybe expect, blah, blah, blah. Is that going to be helpful, or is that going to be too much? Or this is how I typically work. You let me know if it's too much and we'll stop, recalibrate all of that. So we're still flagging that this is my general approach because we want to have that general approach. However, letting you know that we can change this approach if that's what you prefer. That's probably a good way to try to marry the complexity of individuals with these good general principles, I would say. But then you also using your clinical judgment around, is someone being flabbergasted from my compassionate approach, and just bringing it up in the moment too, rather not just at the start.
Maybe if you get that vibe, you might check in with them and just let them lead the way, yeah?
Yeah, and look, in my personal experience, I haven't really had that, but I'm doing 50-minute sessions with people. What you're talking about is like bam, 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 quick, especially preoperatively, right?
Yeah.
So you may see that kind of, I appreciate your intent, but this is a lot. Whereas for me, my small moments of choice and collaborate over a long period of time. And maybe the population I'm seeing is different too, I guess. I think that's important to reflect on, is what does the person in front of me need, even though I've got these general ways, how can I individualize it?
Yeah, so be individual, like individualize your approach on a good basis of a trauma-informed approach, but be prepared to modify it.
That's such a good takeaway. With collaboration, that's highlighting that too, right? It's the spirit of cooperation. So that may have to involve negotiation for the specific person in front of me. So the last principle is empowerment. Maximize empowerment in conversations and within the setting. So especially those of us who have experienced trauma, and especially those of us who have experienced that prolonged, inescapable interpersonal trauma, there's so much disempowerment with that, just immense. So feeling more empowered, even in a pre- and post-operative setting, is healing for that person. They're going to live the rest of their life, but you've given them a dose of empowerment. Using these 5 principles is awesome. And especially, again, I'm coming back to pain, but in pain, more women are diagnosed with an autoimmune disease or chronic pain than men. I do think the prevalence is low, but people of colour as well have a high proportion of chronic pain, autoimmune, inflammatory diseases, that kind of thing. So it's really important that, unfortunately, due to pain being a very specialised area of healthcare, that without that training, we can really invalidate people. We can really misdiagnose. We can really cause harm, to be honest, without treatment of or mistreatments of people. And then if you're someone who has immense interpersonal trauma, we're going through the healthcare system being dismissed, ignored, invalidated, mistreated, coming to surgery on top of all of that. Hopefully now you're in surgery because you have the right diagnosis, all that kind of stuff, but that person is carrying everything. So a lot of the people that I see are actually becoming very avoidant of healthcare.
Yes.
Because of their previous experiences, which is very alarming because it means they might not seek appropriate care. So from that lens, even without knowing someone's story, it's really important that we are providing a safe, empowering health experience, even if it's for a standard procedure, because that's evidence to that person that healthcare can be safe and appropriate, and they will continue to get healthcare in their life. They may tell their loved ones that this was a good experience, and it helps them stay within the health system too.
Yeah, definitely.
And with empowerment, we're looking at maybe someone's self-efficacy too. So that's someone's confidence coping. Basically, how effective do I feel coping with X? And those of us who have been through trauma, it really erodes our self-worth and self-esteem, which also includes our coping abilities. So when we're thinking about empowering someone, it's really like, okay, what makes you feel confident and capable of coping in this setting? Is it minimizing the lights? Is it doing something helpful for yourself to really foster that empowerment within the person?
I went to a great talk by an anaesthetist on communication and hypnosis, and he'll often, as he's putting patients off to sleep, give them some words for what they can expect when they wake up.
Oh, interesting.
So things like, you're going off to sleep now, and when you wake up, you'll be in recovery, you'll be comfortable, you'll be able to look forward to have something to eat and drink. We do the preoperative assessment where we're talking about the risks of nausea and vomiting, the risks of pain, but then as they're going off to sleep, we're actually using positive words. We're preempting comfort, we're preempting a good appetite. So I suppose that potentially is helping people on that empowerment journey.
Yeah, because I guess empowerment involves interactions of validating and affirming, normalizing, building on their strengths and capabilities, using inclusive language. And so it's filtering into what does that look like practically? And I think this communication is a good one. And in case there's nerds listening like me, it sounds like something called Copahead from dialectical behaviour therapy.
Okay.
Basically, the Copahead skill is we first identify a difficult scenario. So it could be an exam's coming up, maybe my fellowship exam. And step 2 is imagining what could be difficult about that. It's probably emotions-wise, thoughts-wise. And then brainstorming, okay, what skills can I use to cope with that? And then it's imagined rehearsal. So kind of like elite athletes, how part of their training is imagining winning the race or whatever it is.
Yeah.
Copahead's kind of like that. So it's like, all right, I'm imagining myself in the fellowship exam. I'm aware that I'm stressed and anxious. These are the things I'm going to do to cope. Study a certain way, deep breathe on the day, have a celebration after. And then I imagine myself doing those coping strategies and imagining myself doing the exam or finishing the exam. And so I like what this colleague of yours has suggested. You're almost doing that imagined rehearsal for the person, being like, this is what you're going to expect. So I feel like there's probably evidence-based principles within that as well, like from DBT perhaps. Yeah.
Wow. That's really mind-blowing.
Yeah, sorry, a bit of a tangent.
No, not at all. And I feel like I could just sit with you for hours and I would just learn so much chatting with you. But unfortunately, I'm just going to say, wrap it up just because
time's the enemy.
Is there anything else that you'd like to say? Is there anything that we haven't covered?
I guess the only thing I maybe didn't say in trustworthiness was around respectful and professional boundaries. So being containing and predictable as a health professional is just as important and more important than being someone that's overly coddly or pushing the boundaries of what's appropriate to support someone. So yeah, that would just be a caveat to keep in mind of what's respectful and professional. But yeah, I guess, look, my takeaway is being curious about how can I foster more safety. I think training, professional development training within your setting is really, really helpful. The Blue Knot Foundation, they also have a helpline. My understanding is that professionals can also call up and be like, hey, what can I do about this? So they're a really good service. It's very humbling, though, I will say, working in a trauma-informed way. So there's always stuff to learn, unlearn, relearn, and it's about humbling ourselves enough to be okay with that process, because it makes us better clinicians and then it gives our patients a better experience.
That's a great takeaway message. I think it applies to everything, not just in terms of how we approach our trauma-informed care, but
so true.
just be prepared
So
to
true.
learn and relearn and take that humility with us into our professional lives. That's so wonderful.
Yeah, we're humans too.
Yeah, exactly. But look, it's just been so educational and informative having a chat with you this morning. Thank you so much for your time. I've certainly taken some things away, and I hope that anyone listening to the podcast will as well. So thank you.
Thank you, Suzi. This has been so fun.
Well, I hope you enjoyed that conversation, and hopefully you found one or two things that you might take away, reflect upon, and possibly put into practice. Bridgette mentioned the Blue Knot Foundation, who provides support for survivors of childhood trauma and their friends, families, and loved ones. They also provide training, and there's lots of resources on their website, which I recommend you check out. If you do have a read or even do their training, let me know. I'm curious to hear how you found it. Is it something we should be making available for more ASA members? Give me your feedback on podcast@asa.org.au. If you enjoyed the conversation in this episode, then some other episodes of the Australian Anaesthesia podcast you might enjoy listening to are episode 55. That's where I talk with doctors Annette, Webb and James Auld on how we can better communicate with children using or borrowing techniques from hypnosis. There's some great tips in there, and of course they're applicable to adults as well. There's also, speaking of communication more generally, I'm hoping you've seen the email about the ASA Leadership Communication online course program. That's a bit of a mouthful. That is being provided by communication expert and coach Dr. Andrea Woznicki. I've already done a few of her courses and they are fantastic. I highly recommend. If you want to hear more about Dr. Woznicki, then we chat in episode 60 of this podcast. She does have her own podcast called Talk About Talk, which is how I first met her in our little podcasting community. And that is also well worth a listen. If you really want to up your communication and leadership game, then consider joining us at the Australian and New Zealand chapter of WELI, which stands for the Women's Empowerment and Leadership Initiative. At our last book club event, we covered some of the material in one of Dr. Woznicki's online communication courses and then delved into it even further. More details from two of the original founders, Professor Nina Deutsch and Associate Professor Larry Schwartz, about the original WELI program can be found in episode 83. I'll put links to all of those episodes as well as to the Blue Knot Foundation in the show notes, so you don't have to just keep scrolling through whichever podcast app you happen to be using. And finally, thank you for joining me for this episode and exploring trauma-informed care with me. I hope you found something to take away. Our patients really value it when we show up as human beings, as well as the highly skilled experts that we are. AI robots have not replaced us yet, and I sure hope that doesn't happen soon. I hope you continue to make a difference and that you and your patients stay safe and well out there. Thanks for listening.
This has been Australian Anaesthesia, produced by the Australian Society of Anaesthetists with many thanks to host and editor Dr. Suzi Nu, with music by Soda Lime Music, sound and engineering by Behaviours, and graphics by the ASA Communications team. For more content, please visit www.asa.org.au.